This is the fun part. We get to ask questions. And one disclaimer, I'm not a handwriting expert. So if your handwriting is challenging, God knows what kind of question will come out of my mouth. And I apologize for that. We've got a lot of questions, and I apologize also if we can't get to them all today. I'm going to start out with one question that I think Dale may have answered for Dr. Vork. But this is a question, did OEHA perform a sensitivity analysis of the impacts of alternative GI absorption assumptions on the model results, particularly for conclusions regarding the impact of particle size on estimates of uptake of lead from inhaled particles? A simple yes or no would do, Kathy.
A qualitative sensitivity analysis, I guess, is the answer. We did not do a quantitative sensitivity analysis. However, we ran hundreds and hundreds of scenarios, and we also extracted from sensitivity analysis, or learned from the sensitivity analysis that other researchers had done, and focused on those parameters.
Okay. Anybody else can always chime in about a question, so don't hesitate. Another question: the model appears to be based on consistent lead exposure. How well do you think the model will work for intermittent lead exposure?
Yeah, I think it's going to work reasonably well, because the short-term responsiveness is not huge, but it's going to tend to average out over a longer time.
Okay.
Because you've got the shorter-term compartments, which have of the order of 1 or 2 months intrinsically averaging, and to the trabecular lead, which is more like a year or so or two, to the deep bone lead, the cortical lead, which is going to be effectively smearing things over decades.
Smearing, is that a risk assessor's?
I think it's graphic, right?
It's graphic. It is graphic.
We want to be graphic. Right.
Thank you for that.
We want to communicate the messiness of it.
Well, don't go too far in that direction. You could have a problem. So a question from the web: the half-life of lead in bone is assumed to be in the order of many years. The Leggett Plus model predicts that it will take less than that to reduce blood levels by 50%. Is there an inconsistency here? Volunteer.
No. Basically, a relatively modest portion of the lead in blood is maintained by the retransfer of lead from the bone to the blood. A lot of the lead in blood is in rapid equilibrium with stores in the soft tissues.
Yeah. Exactly, and to just expand, on that, think of it. It's a multi-compartment model, right? So the fast compartment, which is blood, when you remove someone from exposure, that falls relatively quickly. So you'll see something that goes down quickly, and then it'll come down slower. So the initial decline is due to the soft tissues, that labile compartment, being quickly reduced because you're turning off exogenous exposure. And then you have a slower decline. So it's a multi-compartment decline. It's not a steady decline.
Now, just remember, everybody's looking at me. These aren't my questions. They're their questions, okay? So you don't have to explain to me. Okay, so a question about pregnant women, and it says for Dr. Kosnet, Dr. Vork, but anybody. What are your recommendations for protecting pregnant women exposed to lead in the workplace? Want to summarize those for everybody today?
Sure. Pregnant women are particularly vulnerable because of all the endpoints that have been studied, the effects on the developing nervous system of the fetus and the young child are considered to be the most sensitive. And the lead is transported transplacentally, so if a pregnant woman is exposed, her fetus is going to be exposed. And generally speaking, when you have mother-infant pairs, the baby's born with a lead level which is about 85% of what the mother's is. So right now, the current guidance, for example, by CDC, is that children should have blood levels maintained below 5. So that's why we think it's prudent for pregnant women to maintain blood levels below 5.
Anybody else? No? We're okay? Okay, this is...
Yeah,
yep.
I mean, this is probably further than a California state agency can go, but I think a case can be made for not having women work at all around lead during pregnancy. It's probably illegal to do that because of sex discrimination, but it's probably good public health. And a lot of European countries actually take women out of leaded workplaces for the duration of pregnancy, and of course pay them at the same level for doing other work. It's something to consider.
And one admonition to the panel, grab the microphone, put your mouth near it so everybody on the web can hear you, because we're having a little trouble on the web, so keep that in mind. A question for the web, what are your thoughts, Dr. Kosnet, about chelation treatment for low-level blood lead to prevent long-term consequences?
No, there's no evidence that chelation for individuals with low levels of lead exposure would avert long-term consequences. And actually, if you look at the amount of lead that's mobilized by a course of chelation in comparison to even recent exposure, it's relatively modest. So I think there is no role for chelation in low-level lead exposure.
Could I expand on that further? I agree exactly with what Michael has said. I get very cross with people that come to me clinically and request chelation therapy for the treatment of various ailments. And I say what Michael has just said, that there's no evidence of benefit. And I also note that there's positive evidence of harm. There have been fatalities from chelation, especially self-administered oral chelation, and the fatalities apparently are the result of the fact that the chelating agents are non-discriminant. They go after any divalent cation such as calcium, magnesium, and pull it out of the body as readily as they pull out the metals.
So I would just add, by no evidence could mean there are no studies or there are negative studies. And I believe there's some sort of negative studies that it doesn't help, not just the absence of studies that it might help.
Okay. All right, Dr. Vork. What is the basis for the clearance time assumptions for particles deposited in various portions of the respiratory tract? Are there documentation studies to support these clearance estimates? And then is there similar documentation for the GI tract condition estimates?
One exercise that we carried out and is reported in our report is that we ran the MPPD2 model in deposition and clearance mode, and that showed that a 5-day tracheobronchial deposition of lead in radiated workers was rapidly cleared by the 7th day. And can you restate the question again? I answered.
Well, you know, if I could find it again, I would. So it's the clearance time issues and the documentation for clearance time in the model for lung and for GI. That's essentially, they're looking for substantiation. How did you come to those clearance time estimates? Are there documented studies? Or did you guess? I know risk assessment. That's the one thing.
Well, like I say, we ran the MPPD model in one case. One of the external reviewers suggested that we use an assumption of highly soluble particles that clear rapidly. And that's as far as we went.
Okay. Yeah, sure.
I don't know precisely what the question means by clearance time, because I think if they're talking about percent uptake, I can address that. If we're talking about percent uptake from the gastrointestinal tracker, yes, there have been there are empiric data to support the ranges that were applied by Dr. Vork in that parameter. There have been studies done with stable isotopes administered to humans. There has actually have been some inhalation studies that were done in the early 70s with some short-lived radioactive isotopes and looking at uptake. And essentially, there is consistent evidence that lead deposit in the alveoli is very extensively absorbed, approaching 100%, particularly for fine particles, and that in the gastrointestinal tract it depends, as the model assumed, based on the amount of food, and that lead on an empty stomach is absorbed perhaps up to 50% in an adult. And with the presence of food, it's considerably lower. It could be about 15%, 12%. So I thought it was actually a fairly sophisticated job that OEHA decided to actually assume not just one absorption level for lead in the gut, but to actually model how much might be ingested on an empty stomach with food and with liquid, and that's actually a very sophisticated step to do that, and I thought that was a positive thing that they did.
So, go ahead.
Just want, as I mentioned in my talk, that was based on multiple studies that Dr. Leggett had synthesized and summarized in his 1993 description of his original model.
And it's based on, the important point is it's based on experiments conducted on humans.
So most of the questions, you know, relate to the model, but here's a memory question for you, Barbara. Are you ready? Please restate the comment about ZPP test from slide 6 on page 3.
Happy to. What we said was we recommended that blood lead testing frequency be increased, but we also recommended eliminating routine zinc protoporphyrin testing. And the reason behind that is that though the results of the ZPP test are not useful, the ZPP doesn't begin to rise until you get blood leads at higher levels, above 25 or so and higher. And so you're paying for a test that isn't going to give you useful results. So we think there should be a trade-off with more frequent blood lead testing.
Okay, very good. You passed the memory test. The assumption of a 26 liter per minute inhalation rate is higher than typical occupational standards. How would the air lead estimate change if 20 liters per minute was assumed?
26 meters cubed per day is multiplied by the 30% transfer rate, and that fits the data very well.
She said smugly.
To lower the breathing rate would would mean that the model would not fit the data as well. That's one thing. And also the original Leggett model assumed 15 meters cubed per day for the general population and an overall absorption of 37%. So there isn't a large difference between those two estimates.
Okay, very good. Okay, Dr. Kozna. Now, I'm going to try to read this question, and I apologize to the author if I get it wrong. This is about blood pressure. Rather than postulating varying susceptibility of the population to low blood leads relative to blood pressure, is it also plausible that a portion of those studied had greater elevations in bone lead, reflecting greater cumulative lead exposure, accounting for higher observed blood pressure? Would it be possible to adjust for bone lead when evaluating the relationship between blood lead and body burden, I think? I'm not 100% sure. For example, in the normative aging study. You get it?
Yeah, I do. Let me restate the question.
Thank you.
I think,
please do.
I think it's saying that if you were to evaluate in a population the impact of blood lead as a predictor variable on the one hand and bone lead as a predictor variable on the other, how might their presence affect one another? And actually that has been done in the normative aging study. And when you look at the normative aging study, for example, either in the prospective analyses or in the cross-sectional analyses, when you enter blood lead and bone lead in the model, blood lead is not significant. It falls out of the model. Okay, the effect of lead on blood pressure is more accurately captured by long-term cumulative exposure as reflected in lead in bone and not by lead in blood. So the studies where they've had both measurements, bone lead has been more predictive.
Okay. This person's been doing Twitter too long. Okay, Vork's PBK model, period. Question on solubility assumptions of lead, air gut exposure into blood. Lead compounds, except acetates, nitrates, chlorides, are generally insoluble. Basis, question mark.
That is a tweet.
It's a tweet. Perhaps it's a tweet.
We had to pick something, and if the high solubility was the conservative choice, and that's.
There's actually, and I would add, there's actually a study by Morrow. I think it was in 1999, although I have to double check on that. That looked at fine particles, and the absorption actually did not differ much from the alveoli, depending on based on the solubility. There was, and somewhat to my surprise in that study, that the absorption was fairly good as long as the particle was fine. It was a very fine particle from the alveoli, which most alveolar particles would be. The absorption was fairly similar.
Okay, Barbara. Based on the lead program, California Lead Program's data for 2012, existing efforts, regulatory and otherwise, are incredibly effective and successful. Only 4 tests were over 50, and total number of employees tested over 30 is less than 100. Shouldn't this tell us that we are on the right track and should concentrate on education, outreach, and assistance?
Okay. Didn't you hear what Leslie had to say? Guidelines are good, but standards are better. I hoped that one of the key messages in my presentation was really to highlight one of the key limitations of registry data, which are how many lead-exposed workers don't appear in our registry data due to lack of testing or don't appear in the right industry due to missing information on the blood lead reports that come in. we have done over the years quite a lot of different things to try to impress upon employers the value of blood lead testing. First of all, to see if your safety program is working, to see if blood leads are going up, while they're low, so that you never have anybody on medical removal protection and don't have the economic and disruptive consequences of having people out on MRP. So we will continue to do everything that we can to try to impress that upon people. But standards are an additional way to help convince people of how important this is. One other point that I made in my presentation was that one of our previous recommendations to Cal OSHA was uncoupling blood lead testing from air monitoring. Having a trigger for required blood lead testing that of, airborne lead levels as high as 30 micrograms per cubic meter is just not adequate. We have those situations where ingestion exposure is going on. We've seen significant lead poisoning cases over the years. Low air lead levels, or something changes in the workplace over time. So low air lead levels, creep up. But we haven't talked a lot about ingestion, but ingestion really is the way a lot of workers end up getting elevated blood lead levels. And so this can be picked up by frequent blood lead testing, and it would be a service to employers to have that information on which to evaluate their lead safety efforts, and we strongly promote it.
Ken, did you want
Yeah, I just add some data from Michigan in that some of the worst actors in this, they're not doing blood lead testing, and because they're not required to do it, and they're just not doing it. So some of the most interesting results we see is where the family practitioner, their private practitioner does the blood lead, and then you go back to that facility, and there's just no controls whatsoever. So if there was a requirement to do blood lead, I think you'd find some of these companies, or more companies, you'd find a much higher percentage above whatever level you want to pick, 40, 50, 30.
I just would like to echo what Barbara and what we've just heard. And now I'm speaking as Leslie Israel, the person in the trenches, but, I have cases referred, and it's sometimes because the children were identified with elevated blood levels. And so they'll say, oh, Leslie, because we're an AOEC clinic, I get a lot of calls, and this is something I have to handle, and I have to treat the adult. And guess what? The adult works in one of those places where it's a small employer. They have no regs. There's no regs, and the guidelines, they're not able to follow them. So I think that you're right. I think that if we put in some regs, I think the numbers would go, we'd see the problems. It sort of reminds me of mammography and how the diagnoses went up when the technology or the regs were there.
Okay, Dr. Rosenman, since you made news, there's a couple questions here relating to your little news flash. In relation to the relationship between blood lead and mortality from lung cancer, lung laryngeal cancer, was there data tested on workers regarding cigarette smoking status, and were the results adjusted for that confounder? And then we had a question from the web, which must have come in before you started speaking. Can any of the speakers address the relationship between lead exposure and cancer?
Okay, so the answer to the second question is yes. And if you go back to the NTP document or the EPA, there's whole sections there on cancer. And so, as I said, the animal studies, some of the mechanistic studies are very clear on the effects of the carcinogenic effect, but the epidemiologic studies are mixed. There's stronger studies on kidney cancer maybe than lung cancer. So there are a number of limitations, which I guess I didn't express in terms of the data. One is, so this is registry data from these 11 states, and they don't have cigarette smoking data. So to see that, one would have to assume that the people with the higher blood leads were more likely to be smokers. And And that's maybe possible because we know people who smoke actually, you know, they get it on their hands and then they start smoking, and so that's a possibility. The other limitation, which wasn't part of the question, is the work exposure is not controlled for. So potentially the people with the higher leads are in smelters, and they may have other exposure to other carcinogens, particulates, or arsenic or something. So there are some limitations to the data I presented.
So this next question to me is very interesting, Dr. Landrigan, and it can be answered, I think, from a very sort of 50,000-foot perspective. With all of this evidence confirming the hazardous nature of lead, why is it still so common? Are there no alternative substances? If not, why is industry not getting working to develop alternatives? Why do we still have this problem?
That's a very interesting question that opens up a big door. And the interesting thing that I suspect many people in this room don't know is that global production of lead is actually on the increase right now, despite the fact that we've taken lead out of gasoline in all but 5 or 6 countries, such beauty spots as North Korea and Afghanistan. The global lead production is going up, and the reason, in a single word, is batteries. We need lots of batteries in today's world. Every little cell phone or BlackBerry has a battery, but also a Prius has a great big battery. And that trend appears to be something that's going to continue. So the problem's not going away.
Substitutes?
Certainly people have looked for substitutes. Lead has advantages. It's cheap and it's abundant. It has disadvantages. It's heavy. And it's toxic, and so there's lots of motivation to look for substitutes, and substitutes have been found in certain applications, but it's still the economic winner, especially for the big batteries, as I understand it.
Thank you. Okay, Dr. Vork, you've been resting a little too long, so we'll go back. The Leggett Plus adjustments were primarily based on data sets from times with very different ambient and non-work lead exposures. Did OEHA correct the model's assumptions based on current ambient lead exposures? Is the difference in background lead significant?
Yes, it is significant, and yes, we did correct for it when we did our tables for Task 1 and Task 2.
Great. Okay, so this question is for Barbara. Just to make sure I follow, is the California Department of Public Health recommending both an airborne PEL and a blood lead PEL?
Let me rephrase that question, or try to. I think what they mean is, do we recommend a PEL and a medical removal protection limit? And yes, we did recommend both. I focused more today on our PEL recommendation and where it came from. But Dr. Kosnit also put up on one of his slides recommendations for medical management that are identical to the ones in the Environmental Health Perspectives article and in our 2009 medical guidelines. And they recommended medical removal at a single blood lead of 30 or 2 blood leads 4 weeks apart above 20, as well as all of the guidance that you would do and focus on reducing exposures on the lower blood lead ranges.
And I would add to that that the recommendation, if I understand it correctly, Barbara, is also allows a physician's discretion to recommend removal at a lower level if there are reasons to believe that the person has enhanced susceptibility, is vulnerable on the basis of long-term exposure, or, for example, in the case of pregnancy.
And maybe it's more of a question or statement, but did not the California Department of Public Health then review or update the guidelines which you released in 2013, and maybe the levels are still the same, but you changed some of the wording? I thought there was a sort of an update of the medical management guidelines. No? Okay. I thought that's...
No, we took essentially the same table, and that was what was considered by the Council of State and Territorial Epidemiologists for a lot of that information is used on laboratory reports when, blood lead test results come back and there's, information about, what you should do about those levels. So some of that information is in that recommendation as well.
So Dale, you commented on this, and maybe this is something that you want to comment also again, and maybe Kathy can comment too. Assumptions about the breathing rates do not appear in the model, do not appear to account for gender or racial ethnicity males, non-white males. And you assume something on work 8 hours a day. What effects would there be on your model if workers were non-white and or female and worked 12-hour days? How would that affect the recommendations for a PEL?
A change in the hourly number of hours worked is something that would straightforwardly affect the intake of the of lead. So it would increase the amount of lead. But in implementation of occupational standards, it's the industrial hygienist has the option to take that into account, as I understand it. That if a PEL is set on an 8-hour basis and it actually the workplace works 12 hours, I think you could it goes down. Right.
Just in from the online, just wanted to let Dr. Landrigan know, hybrid batteries do not contain lead.
If I'm wrong, I stand corrected. I don't know if
Okay.
I'm wrong, though.
Thank you for, this is why we have people online, because they can keep us honest here. Dale, did you want to finish that thought? Sorry.
There wasn't. I don't believe that there's a huge difference between males and females in breathing rates, although I would be open to data on that. There is a serious difference with pregnancy there's data on that. So in adapting the model to pregnancy, you would want to change the breathing rate and probably also the uptake characteristics because of the increased transport of calcium by the same transporter that also transports lead.
So this question, I think, has to do with the reversibility of the findings, Dr. Kosneth, that you pointed out. The studies of hypertension, cardiovascular disease in populations with reduced blood or bone lead levels. In other words, I think they're talking about, is this effect that you're describing, hypertension, cardiovascular, is that reversible if you do something with the lead levels, like reduce them?
That's a good question. I don't know that question, the existing data adequately addresses that. Most of the the data that best describes the risk is associated with long-term cumulative exposure, and I am not aware of studies that have specifically addressed whether there's a dynamic change in time with exposures go down. However, I will point out, and I think it's relevant to look at, if you look at, for example, the studies that have been done in adults today, the recent cross-sectional studies that show, for example, going from a blood lead of, like Dr. Menke's studies, going from a blood lead of less than 1 to greater than 3, and that there's a change in cardiovascular mortality. Those don't reflect probably the recent exposure. They reflect the exposure that those individuals accrued earlier in life. So their exposure ended. Their high exposure above 10 ended, probably in the 1980s. Yet we're still seeing an effect on their mortality as a consequence of their past long-term cumulative exposure. So it may not necessarily be reversible, and if it is, it's certainly not a quick thing. It doesn't. Your risk of lead-induced cardiovascular disease and hypertension doesn't end the day you lower your exposure. It goes on for quite a while.
So this next question, Barbara, is from an industrial hygienist, and I'm not qualified to read it even, but I am going to try to read it, and then your job is to see if you can interpret it, okay? There's lots of numbers here, okay? Assuming a typical 8-hour air sample taken at something that looks like 1 p.m., or maybe that's what... there you go. 0.96 meter cubed of air is sampled per shift. This gives us reporting limits for 3 common analytical techniques to be FLAME, AA,
Atomic absorption.
3 micrograms per meter cubed, ICP, 0.9 micrograms per meter cubed, graphite furnace AA 0.2, blah, blah, blah. Assuming you want an analytical reporting limit of at least 5 times, 10 times would be better, below the PEL, what about the action limit, question mark? The only semi-standard analytical technique that will get that low is ICP-MS. There isn't the capacity in the U.S. to do this work, and the price would more than double even if there was capacity. How is this going to be addressed?
Well, thanks for that question, Dr. Howard. You know, as I said in my talk, Cal OSHA does have to address both economic and technological feasibility for arriving at their final standards. And technological feasibility does include things like, can you measure it adequately? You know, it has to be considered both for the air and for the blood. So, you know, these things will be addressed as Cal OSHA moves forward in the process.
Thank you, Barbara. Okay, Dr. Dvorak. Now, there's a couple questions here, I think, relating to models, and I'll read them both. How dependent are the airborne lead estimates on the choice of the modified Leggett model, question mark? What about the original Leggett model, the O'Flaherty model, the EPA adult lead model? Another question, the adjusted Leggett model fits the ASARCO data. How well does it predict other data sets or individual data? Does it or blood fit better the model? Several questions about the model and the choice of the model, et cetera.
We did consider those other models, and the all ages lead model was actually under revision and not available when we went through this analysis. The O'Flaherty model is you saw how complicated the Leggett model. Well, the O'Flaherty model is about, I don't know, 10 times that that complicated. And what we were able to get was an executable of the O'Flaherty model, and it actually over-predicted blood lead levels for the data sets that we looked at. The original model, as you can see in my presentation, under-predicted the blood lead levels. So, and as far as other data sets, we did try to get a data set of the Canadian smelter workers that were referred to in the NIE study and a study by Fleming and others. And they were not able to give it to us because of human subjects issues.
Okay, thank you. Now, I'd love to hear the answer to this question, so I'll pose it to the entire panel, although it says for Dr. Kosnet, I don't know why. How persuasive is the data underlying the Kevin Drum article, I guess, or contention in Mother Jones, that decreasing lead levels explain the decrease in American youth violence?
There's a fascinating correlation that was published in that journal that John alludes to. And what it showed was the following, was that it begins by pointing out that the rate of murder in the United States has declined precipitously over the past couple of decades. And the authors pointed out that the decline in the murder rate took place just about 20 or 21 years after the decline in blood lead levels. The decline in blood lead levels started in 1976 when EPA took lead out of gasoline, and a few other things were done at the same time, like getting lead out of tin cans. And it was largely completed by 1982, something like that. And the decline in murder rate began just about 20 years later and extended over a 4 or 5 year span. So the hypothesis is that the 1 and 2 year old people, mainly boys, because murder's a male thing mostly, that their decline in blood lead levels in their infancy led to a decline 20 years later, approximately, in the murder rate. I think it's a fascinating hypothesis.
Thank you.
Now, there have been people that have followed up on that paper. I was talking to a health economist at Amherst College in Massachusetts in September. I was up there, and she's been looking at declines in crime rates in various municipalities in the U.S. and overseas that got lead out of gasoline at different points in time, so that you don't just have one data set and no opportunity to validate things. And she thinks that she sees evidence for the same trend in other data sets. So we'll see. I think it's still a work in progress.
Very good. I'm going to have to read that journal. So, Barbara, this may relate to an answer you gave a few minutes ago. Most high blood lead levels are certainly due to operations without controls and excessively high exposures. How are companies that cannot comply with current PEL going to comply with a standard that's 1/10 of that? Why not enforce current standards and analyze results?
Well, you know, again, I think this is something that Kalusha is going to have to examine. We don't have a lot of data on air lead levels because we have operate a blood lead registry, and also because many employers don't share voluntarily their air monitoring data. So I'm going out there on a limb, but I suspect that Kalusha would welcome information from industries about their processes and the associated air lead levels that would contribute to the discussion and the assessment of what's feasible to do for different types of operations.
So following that up, why bother with an air PEL if you will require blood lead testing by all employers? Blood leads are a better indicator of exposure, and a relevant air concentration is not easily measurable. So why not just require employers to implement controls based on blood lead?
I think this topic was really a hot topic back in 1978 when the federal OSHA original standard was passed. Just the whole concept of using workers as guinea pigs, let their blood leads rise and then we'll think about doing something about it is sort of, not acceptable in occupational health. We really, are prevention oriented, and so obviously bringing air lead levels down is, the way to prevent blood leads from going higher. We talked earlier about there isn't a threshold for lead health effects. So, I think our goal is to identify the things that are associated with this excessive exposures and really to, the standard already says that you are required to use engineering controls to the extent feasible to bring down exposures. And I think there has to be more emphasis there to really challenge the industries to bring down levels.
I agree. I think there's a role. I think there's a role for both. I think there's a role for a PEL to guide how we can reduce airborne exposure, but I think that there's also a role for blood lead monitoring, which captures exposures irrespective of the pathway.
So, Kathy, will OEHA revise its PEL recommendation to consider the problem of potential lead exposure of less than 30 days? We're back to the intermittent exposure per year, considering your statement that this is a limitation of the model.
I stated that it was a limitation of the
Dr. Vogt's statement that this is a major flaw in the model.
I stated that it was a limitation in our testing of the model. I'm saying that the data that we used to test the model was from chronic exposures, and it's unknown what the how well acute data or acute exposures would be modeled by the adjusted model. So, however, the original Leggett model did do testing on shorter term exposures. So that's why I made that statement.
Okay. Can anyone comment, and perhaps Leslie, you might be able to do this since you actually maybe do this sort of thing for a living. Can you comment on ZPP levels and cumulative lead exposure? From a scientific standpoint, clinical standpoint, is there any utility at all in taking ZPP measurements?
Actually, WOMA did make a comment about this in 2009 and in 2012. And we said, we agreed, we supported what Barbara's indicated about that there's no role for ZPP when the blood levels are below 30.
Okay. Go ahead.
I would just say, I think for routine monitoring.
For
yeah,
routine monitoring, but for evaluation of a case, which we do see, we would then consider use of ZPP and other methods.
Right. If you see.
So for diagnosis, yes. For monitoring, no.
That is correct.
If you see somebody with a high blood lead and then you measure their ZPP and their ZPP is low, that suggests that the exposure was relatively recent within the past few weeks.
So earlier studies showed men of reproductive age exposed to lead had difficulty conceiving or having healthy kids, if I remember rightly. Why recommend lower levels for women only? What about first having a level that protects the most vulnerable and avoiding discrimination against women?
Well, I'll start because I put up this slide, and then please follow up. What I said when I presented the results about that were evaluated by NTP and EPA was that there is evidence of effects on male reproduction, but those effects are observed at higher lead levels than the ones that we're focusing on for the cardiovascular and hypertension effects. So that if we're going to reduce exposures to keep people below 10 or below 5, then the reproductive effects on males should be, adequately addressed.
Okay. Anybody else?
No, only the philosophical point I try to make in my talk is that I think occupational standards should be set at levels that protect the most vulnerable people in the population, and in this instance, the most vulnerable is the fetus that a pregnant woman worker carries to work with her. And that levels that protect the fetus are certainly going to protect adult males. Okay. Yeah. Right. Are we saying the same thing? Yeah.
So I'm not sure who had this reference. What's the reference for the 1.2 microgram per deciliter for U.S. adults? I think it was you. It was not recently in the NHANES ABLES report. Didn't you show the 1.2?
Yeah, I think I showed 1.2.
Somebody wants to know the reference.
I think Barbara mentioned 1.2. I think I mentioned 1.1. Maybe it's
1.2 for the adult population and 1.1 for the general population.
For the general population.
But it comes from NHANES data.
It comes from NHANES.
If you go on to the National Center for Environmental Health website, they have updated their data from the NHANES portion that they do every couple of years, and the most recent data reflects those numbers.
Okay. So could Dr. Kosnet please comment on how to interpret studies that are finding positive results for bone lead but not blood lead or vice versa? Is there a possible explanation for this, especially when this finding occurs in the same cohort? If bone lead is a more accurate measure of cumulative exposure, how do we interpret the results of studies that focus only on blood lead?
Well, blood lead reflects both recent and chronic exposure. I mean, it reflects recent external exposure, and it also reflects the equilibration or the contribution of lead from bone into blood. So blood lead is a hybrid, if you will. Bone lead is a better marker of long-term cumulative exposure. So I think the data indicates that with endpoints like cardiovascular disease and hypertension, it's the long-term cumulative exposure which results in the risk. And that's borne out observations too on the pharmacodynamics of lead. If you have a short-term exposure to lead, your blood pressure doesn't jump up. Okay, that just doesn't happen. It's the long-term cumulative exposure, and so that's why in these studies that have measured both lead in bone and lead in blood, it's the lead in bone which is the greater predictor in most studies of the risks such as hypertension. Now, we have seen, and I did show some studies that showed a relationship between blood lead and blood pressure. And to a certain extent, that still exists, even though it's not the short-term exposure. It's because people today, if you take a general population, people who have higher blood leads today probably had higher cumulative exposure as well, if it's a large study. So in the NHANES studies, those who have higher blood leads, their blood lead is probably reflecting the fact that they have had longer accumulation of lead in the bone, and that's why their blood lead level is high today. So I don't think there's an inconsistency. I think that overall the findings from the studies are consistent.
So Barbara, we're going to Stockholm now. Should the California Department of Public Health be recommending a lower PEL for women aged 50 and younger, as in Sweden?
I am not an expert on what they do in Sweden. I've been in California for a long time. I think that was a reference to Dr. Kosnitz's slide that showed the medical removal protection levels in the different countries. And, they all looked pretty high to me. So, Sweden ought to look at lowering their MRP level as well.
Well, we'll telephone them right after the... Okay, so have the 8-hour time-weighted averages produced using the Leggett Plus model taken into account dietary exposure and smoking exposure as contributing factors to the blood lead?
We did incorporate a background level of 1.5 that leads to 1.5 micrograms per deciliter in the blood. So that was incorporated into the calculation of an 8-hour time-weighted average.
Okay. So a follow-up, need to see information on younger workers who were not alive in 1970s. Would this information affect the model? And then I'm sure the questioner doesn't mean this in a pejorative sense to your reviewers, but has this information been submitted to more experienced reviewers at Federal OSHA, NIOSH, and ACGIH? If so, what was their response? If not, why? It wasn't meant personally at you, Dale, at all. Okay, well, on behalf of Dr. Vork,
Did you want to respond, Kathy? I now even forget what the first part.
Yeah, the first part of it is information on younger workers who were not alive in 1970s. Wouldn't this information affect the model? How would having a cohort of people who were born millennials affect your model?
So you're saying that people that have a lower background?
I think that's what the questioner is after. People who were not alive in 1970 may have a lower background level.
As opposed to the data that we
now, see, you're
had
going
used.
too far here. No, I'm supposed to ask the questions here, okay? That someone has submitted to me, so no cross-examination is allowed. By the way, have you submitted to Federal OSHA, NIOSH, and ACG? You could answer that one.
My understanding of the model and the Leggett model is, it incorporates a movement of lead between compartments that is governed by age. The Leggett model, the core Leggett model, had some age dependence to the movement of lead in and out of bone, and I think it would. I see no reason to believe that the model would not function with people who are younger and had shorter, lower background cumulative exposure. So I'm confident that the model would be valid. The data sets that were available for use to validate the model were based on individuals who had higher exposures. But the inputs to the model and the pharmacokinetics are applicable to people from younger ages.
Yes, I just want to add to that when we modeled the exposures for adults, we started with a beginning blood lead level, which incorporates any background level. So it could be, less than 1, or it could be 20. So that it's completely flexible in that model.
Okay, so you want me to take on this FEDOSHA,
Yeah, sure. Why not?
NIOSH, ACGH?
Why not?
So, the report summarizing OEHA's work just came out, about a month ago, Kathy? And this is the first public presentation. And we know that there are NIOSH and federal OSHA people attending by webinar. And we expect they'll be reading the report and seeing what they think of it. And we, yeah?
It's posted.
Oh, and it's posted on the website, so it's available for the public to look at. And, sooner than later, hopefully it'll be published in the peer-reviewed scientific literature as well, we hope. That's the plan. And so, this is the first day of presenting it and getting to pose questions to Kathy, but our information is in the packet. Any of us who are speakers today, will entertain further questions about it.
Leslie?
As I recall, the meeting started with, this is a historical day. I believe one of the speakers mentioned that. I also believe that California seems to be the mover and the shaker. And apparently we have an ATD standard and we have a diacetyl standard, which as I recall, FEDOSHA doesn't have. So
Let's not get nasty. Okay.
I'm responding to the person who asked this question, and so with all due respect to the person who asked the question, we hope that today will foster some more questioning of this.
That's a beautiful answer. Thank you. So Kathy, why is a p-value of 0.15 considered acceptable for the Leggett Plus model? Why not consider a p-value of 0.05? It was in one of your slides. I remember that.
Yes, it signifies no difference, which is what we were looking for. And I'd like Dr. Hattis to, he did such an eloquent job of explaining it.
Yeah, the p-value is the probability that you would get as large a difference between your prediction and your observation as you see by chance for random statistical fluctuation. So what a p-value of 0.15 means is that there's at least a 15% chance of seeing a difference as large as was found between the predicted levels and the observed levels. And so it means that you don't reject the null hypothesis in that case, that the model is correct. Okay, so it's different than what the author might have imagined.
Okay. So, Dr. Landrigan, how do we interpret results of studies on several developmental effects of lead where an association is positive for one parameter, such as low birth weight, but not small for gestational age or head circumference, even within the same cohort?
Well, each of those endpoints has its own dynamic, and there's no a priori reason to think that lead would have the same effect on each of those outcomes.
I see. Okay.
Birth weight is a really sensitive parameter that you can get significant effects because of it's a continuous parameter. It has a lot more information than a quantal or a parameter that's interpreted as quantal, like small for gestational age. So it just takes a lot more information in the data to reach statistical significance. So you don't want to interpret a negative response as saying that there's nothing there, but you want to say it's not large enough for us to have found it by our usual statistical criteria.
That's great. So it's 3:40. We're going to conclude here in a few minutes. So I've gone through all the ones, our web questions. I want to make sure that the web folks were taken care of. And I've got a few others, but I wanted to also open it up to see whether folks had can we get this gentleman a microphone so that he could be heard? Thank you.
Just going back to what was discussed a little while ago as an employer, and without taking any position on proposed new PELs, it's really important for us to test and to sample so that we know where we have exposures, if our control measures are effective, and where they're not, where we need PELs. So I think it's really important. I agree strongly with Barbara that sampling needs to continue, and we can't just depend on blood leads. I would say that the typical sampling that we do has a reporting limit of quantification above 2 typically. So there are some potential challenges there at very low levels. My question is, would testing bone lead be a better measure for protecting workers long term? And is there any practical way to do this in an occupational medicine arena?
Well, right now, the technology is not practical, I don't think, for having routine availability at work sites across the country. Also, remember that the lead in bone reflects a long-term accumulation. So a person could run up some short-term, potentially deleterious effects, for example, on reproductive outcomes before they would manifest an increase in bone lead. Technology may change in the future. 20 years from now, there may be other devices that are available that could do it very quickly and sensitively, and it perhaps might add valuable information. But right now, it's not practical.
And we were talking at lunchtime of practical limitations. There's only 2 or 3 instruments in North America for doing bone lead. It's the same basic physics as the handheld XRF that you use to sample paint in an old house or to look for lead in the soil, but the highly sensitive, very precise detector that's needed for the bone lead, we've got one at Mount Sinai. My friend Andy Todd, whom you mentioned, Michael, and I think there's one in Toronto, Howard Hu, and there may be no others.
Argonne Labs.
Argonne, you mentioned at lunchtime, that's right. Thanks.
Short follow-up, and then we have to go to another question.
Some of the things we've been talking about today are based on the intent of changing the regulations is to address these long-term, over the entire work life kind of issues, and if we can't test for them, and if the blood leads aren't really predictive or protective of them, are we at kind of cross purposes here? Or are we not really examining the workers thoroughly?
No, I don't think so. I think that you can't look at a blood lead today and necessarily infer the person's past exposure. But if we have a worker in the workplace and we're monitoring their blood lead and we're seeing that over their tenure at the workplace their blood leads don't get above 10, then we can be confident that they're not accumulating long-term exposure.
Other question here in the auditorium? I saw, yes, sir.
I don't think I
No, we need it for the web.
okay, good point. Okay, this is for Dr. Materna, and I apologize if I butchered your name. 2 quick questions, they'll be easy. I went to a D2 school. What triggers testing? What mandatory testing in California?
Are you talking about blood lead testing?
Yes.
What is the trigger? Exceeding the action level of 30 micrograms per cubic meter for more than 30 days a year.
Okay, so this is part of your problem for
A month,
collecting the data?
30 days a year, sorry.
So this is part of the problem collecting the data? Is there's people out there that don't know that they've hit that mark?
In our experience, there are many employers out there, particularly small employers, who just don't do air monitoring. I think the people in the room here are pretty darn familiar with the lead standards, but that doesn't mean that awareness, extends across all industries, large among large and small employers. So yes, air monitoring, costs a certain amount of money, takes a certain amount of sophistication. There are many workplaces that don't have an industrial hygienist or a health and safety professional who can conduct air monitoring, so they have to hire consultants. So for whatever reasons, there are a lot of employers that don't do it, and yes, then they're not and they're not required under the current CalOSHA standard, then, they don't know what their air lead levels are, so they're not required. So the recommendation that we made is to devise some criteria for what a lead workplace is. Something that focuses on lead is disturbed or used in a way that it can be released into the environment, not just solid lead that sits there undisturbed, but some, process that disturbs lead should be the trigger for when putting your workers in the blood lead monitoring program, must be done.
Okay, and then the second thing, just so I'm clear on what I think you said, is, okay, your recommendation was an MRP of 30 and then a return to work at 2 consecutive 20s.
No, that's not correct. So it was 1 blood lead of 30 or higher would initiate medical removal, or 2 at 20. When you get up above a certain level, then you do more frequent blood lead testing. So say you did it 4 weeks apart and it was still above 20, that would be enough to require medical removal protection.
And then what's the return to work level?
Well, we recommended, this was back from our expert lead panel and the EHP group. We recommended a return level of 15, which I think some people could validly say is, inconsistent with our current recommendation that people stay below 10. But, that was the recommendation that we made at that time.
And the PEL was 2.1?
The PEL recommendation we gave as a range of 0.5 micrograms per cubic meter to 2.1 micrograms per cubic meter. The lower number would keep 95% of workers under 5, their blood leads, and the higher end of the range, 2.1 micrograms per cubic meter, would keep 95% of workers under 10 micrograms per deciliter.
Michael, did you have a...
Yeah, I'd like to just add a point for emphasis for people to realize, too, is that the goal is to keep people long-term with blood leads under 10. The fact that medical removal is not triggered until 20 doesn't mean that it's fine and okay to keep people long-term with blood leads in the teens. I think the message that I want you to take home is that if you have blood levels in the teens, we want you to take action. We recommend on a health basis you take action to lower those levels. Medical removal, which is a fairly severe and extensive action, is at 20. But that doesn't mean that our guidance is that below 20 is fine. Okay, we'd like people to go below 10. If you have people who are in the teens, take action, but consider removing them based on the situation, but definitely try to structure your long-term goal so it's less than 10. And then if you're above 20, it's gotten to the point where you have to remove the person if it's repeated at a level of, if it's repeated again in 4 weeks. And I think that's an important take-home point for people to get.
Other questions in the auditorium? Gentlemen?
You mentioned that there was traces of lead found in the ovuli. Did I hear that? Or as far as the respirable dust, you're talking about you finding evidence of lead in the ovuli? Alveoli, excuse me.
In the deep lung, I think, Kathy, you mentioned that in
the deposition analysis that I showed that there was lead that deposited in the deep lung as well as the upper respiratory. Is that what you're asking?
Yes, because currently I know we're not doing a lot of testing during chest X-rays for looking for lead, right? Is that?
Well, it wouldn't. I don't think lead would show up on a chest X-ray. Not these tiny fine particles. The instrument just isn't sensitive enough to pick it up.
Question from the gentleman in the back. there.
That's where it's absorbed from, so it would be absorbed or then coughed up, gotten rid of. So it's a combination, but that's how it gets absorbed into the body.
The
Sir?
smallest particles go deep into the lung and then directly into the blood.
Sir, go ahead.
Any thought on the surface level of lead, which would be, which would raise concern? My understanding is that, that's sort of all over the map in terms of the HUD levels and what OSHA recommends. I think the Fed level is like 200 micrograms per square foot. What would be considered to be a problem at the PEL levels that you're recommending?
I don't have an answer for that today. We were originally asking OEHA to do some work looking at surface contaminations, and the goal of that would be to try to use modeling to define a level of lead on the surfaces that would be sort of a limit for clean areas. So like lunchrooms or places where workers eat, their change rooms, we want to make sure that ingestion is not occurring there. So that was where we were looking at possibly determining a numerical criteria for, what a clean space is. That work got, is available sort of in draft form, but we, due to the time constraints and feasibility, didn't finalize it at this point in time.
Did you have a follow-up question, sir?
Yes, thank you. And that'll take into account the soil lead levels, which is varies quite a bit around the country and around the region.
Another question in the auditorium? Yes, ma'am.
This was asked a little bit earlier, but if you could expand on it. It seems that you validated your model using the ASARCO data, which are people that are pretty much exposed to a consistent level of lead, 8 hours a day, 40 hours a week, and they have very consistent exposure. Many of the workers who are exposed to lead today are exposed in construction, where you're going to have very intermittent types of exposure. Could you do a little further addressing of how well you think the model addresses intermittent exposures to lead, such as construction activities, where you may have a worker that's exposed for an hour here, 2 hours there, but they're not getting a 40-hour exposure in a week?
We have modeled that, and that is a capability of the model. We just did not include that in the report. It is something to be examined, the intermittent exposure scenario. There is a component of the model that has a nonlinear behavior, and so it is something to explore that at high spikes and intermittent exposures could be slightly different than evaluating something as a constant exposure. It is something to further explore. And the model has a capability of doing that, but we didn't have data to actually explore how well it predicts from the data that we have.
The part of the model that has that nonlinearity is the relationship between whole blood lead and lead in the plasma. And our initially looking at the constants that are built into the model, it looks like there's a reasonably rapid equilibration. So if that's the case, then it should tend to average out things over time pretty well. But it needs to be tested as to how rapidly that equilibration really happens.
Other questions in the auditorium? Okay. Well, first of all, I want to thank all 7 of our speakers today. And I want to thank all of you for coming and for all of you who provided questions for the panelists. I think we had a wonderful day, and as Dr. Landrigan told us, it is an historic day. As Dr. Israel also confirmed, this is an historic day, so remember this day. Tell your grandchildren about it. Thank you very much for coming. Thank you, everyone online, and especially those of you who are in time zones other than ours. So safe travels home.